This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. Welcome back to our November headache series. This is our last session. I promise you it's going to be a good one. This time we're going to be focusing on rapid developments in neuromodulation. With me to discuss is our special guest, Stewart Tepper, Vice President of New England Institute for Neurology and Headache in Stamford, Connecticut. Well, Stu, thank you so much for being on the podcast.
It's an absolute pleasure, Tesha.
Well, we had you on years ago, and I have to go back and listen to that because I know we didn't discuss all that we're going to discuss today.
Well, I'm looking forward to talking about non-invasive neuromodulation for neurologists because a lot has changed. We learned a lot more. We have 6 devices that are FDA cleared. It's really a very exciting area where a general neurologist can really make a difference.
And I know you've led a lot of this research, so it's a special treat to have you here. Why don't we talk about, just give us a broad overview of these different devices that are available to the neurologists.
With your permission, what I'd like to do is to start with a case, because I think if, as a neurologist, you're thinking about these devices which are FDA cleared, they're not significant risk, I'll take you through them. It's pretty good to have an idea about the kind of patient you might consider with these. So I was thinking about a 27-year-old woman who I've seen who has disabling high-frequency episodic migraine. So she has headache less than 15 days per month, but these are pretty disabling. And a good neurologist had seen her and prescribed amitriptyline, but she found it too sedating, and topiramate, which gave her cognitive impairment, and propranolol, which made her lightheaded. And for acute treatment, she tried sumatriptan, which gave her chest tightness, and rizatriptan, which was too sedating, and zolmitriptan, which gave her nausea, and naratriptan was too slow and didn't really work. And she tried the 2 oral G-pants, and they were too slow. And she's a working person and didn't want to try lasmiditan because she needs to drive, and her attacks occur during the day. And, of course, she's thinking about getting pregnant, and she wants to stop contraception. And migraine demographics are very often women of childbearing age. So thinking about this patient all along, then we can talk about the 6 devices.
Did she Google you and Googled non-drug options expert?
No, she just challenged me and said, "What are you going to do for me?
Okay.
I need prevention and I need acute treatment, and here's all the things I've tried, and what are you going to do for me? Plus, I need to get pregnant." So that is kind of in my wheelhouse. And so I shared with her what I would share with my colleagues, which is that we have 6 non-invasive neuromodulation devices for migraine, and 5 of the 6 are cleared for both the acute treatment of migraine and the preventive treatment for migraine. And I always say that this is like the Berlin Wall, which got torn down, where one side it was acute treatment of migraine and the other side is preventive treatment of migraine, and down it comes because we have these devices that work both ways. They work both acute and preventive. We have one that's only FDA cleared for acute, but which is being studied for prevention. So probably by this time next year, we'll have all 6 of them will be cleared. So I think what I'll do is just briefly highlight them. There are 2 devices that work almost identically. And these are devices that they use a pad and they go over the eyebrows and they sit over the supratrochlear and supraorbital nerves. And they stimulate the first division of 5, the first division of the trigeminal nerve, by stimulating afferents, supratrochlear and supraorbital afferents. And these 2 devices, one is technically called an external trigeminal stimulator, or ETNS, and the name under which it's marketed is Cephaly. And the other actually is called a transcutaneous electrical nerve stimulator. So it's actually called a TENS, and that is sold under the Hedaterm. So Cephaly and Hedaterm are the two brands of stimulators that go on above the eye and are turned on for 20 minutes, for 60 minutes, for 2 hours, depending on the need. And we'll circle back and talk about those two devices as you wish. The third device that works by a completely different mechanism is a single pulse transcranial magnetic stimulator, or STMS. And this is a shoebox sized device which one plugs in and charges, and then by turning it on, it's placed on the occiput. And when the patient hits a button, it discharges a magnetic charge that goes probably as far forward as the thalamus and as far down as the brainstem and upper cervical cord, probably the trigeminal cervical complex. And it's sold under the name Savvy Dual. So STMS is the third device. The fourth device is a non-invasive vagal nerve stimulator, which looks like a old Norelco razor, for those of you that remember this, and it's placed over the vagus with a little bit of electrode gel and turned on for 2-minute cycles. And it is, again, approved for both acute and preventive treatment of migraine. It has some FDA clearance also in cluster headache and some of the other trigeminal autonomic cephalalgias. So we'll come back to that. And sold under the name GammaCore Sapphire. The next one is a device that goes on the arm. The device turns on, stays on for 45 minutes, and terminates migraine. And if it's used for 45 minutes every other day, it's FDA cleared to prevent migraine. And that's called a remote electrical neuromodulation device, or REN, and is marketed under the name Neurivio. Final device sits over the eyebrows, but it's more like Princess Leia's tiara because it has electrodes that go over the supraorbital and supratrochlear nerves, but also over the occipital nerves and back. So it's a combined occipital trigeminal neurostimulator that is marketed under the name Relivion, and that currently is FDA cleared only for acute treatment, but is being studied for preventive treatment, and preliminary case series suggests that it too works both acutely and preventively. Those are the 6 devices.
So you spoke about the patient, and they all have similar indications, right, for migraine and then some for trigeminal autonomic cephalgias. But just speaking about this patient with migraine, how do you select which device to use?
The first question to ask the patient is she a veteran? If she's a veteran, most of these devices are covered by the VA. The second question to ask is, and I do this with the patient, is are you independently wealthy? Because some people are rich enough that they can afford anything, so cost does not become an object. But most people, cost is a big issue, and not one of these devices is being covered by commercial insurance. There are a few that have carved out individual deals in which commercial insurance is paying for them. There's one deal with the Tufts healthcare system. There's another deal with the University of Utah healthcare system. You have to luck out if you happen to be a patient in one of those systems that where these devices are covered. But in general, they are not covered. Patients will have to pay out of pocket. At that point, it behooves the neurologist to know how much they cost, because we end up going essentially by cost. And I'll be glad to go through those as we go. They've not been studied against each other, so we do not know which is the most effective. And because we don't know that, we end up often deciding based on cost, letting a patient try them for 3 months or 4 months. And if they're not doing well, then moving to the next least expensive device. Each of them is non-significant risk. That's the designation. So that means they're not going to have significant side effects with them. They may feel the device. They may feel odd aspects of the device, but in general, they're not going to have side effects. And although not one of them is FDA cleared for use in pregnancy, it's pretty hard to think that a stimulation of the first division of 5 is going to give anybody a problem. And the single pulse transcranial magnetic stimulator is actually approved in the UK for use during pregnancy. And the one that goes on the arm, the remote electrical neuromodulation device, Audrey Halpern published a paper this year evaluating, actually in a pretty clever way, how gestation ended up, what the size of the fetus was, what the health of the baby was. And there was no concern with respect to the remote electrical neuromodulation device with respect to any of the gestational outcomes. I'm therefore pretty comfortable using Cephally, the single pulse transcranial magnetic stimulator, or the remote electrical neuromodulation device in patients that are planning to get pregnant and really even during their pregnancies. Remember, this is not on label, but again, I'm pretty comfortable. The magnet discharge does not go below the neck, and it's just difficult for me to see how the other ones would pose a risk in a pregnancy. Do you use them, Tesha?
Absolutely. Cost is obviously an issue, and I'm really glad you brought that up because we need to do better in terms of our advocacy and access to care. But given someone that had resources or a veteran, I guess these devices are used differently. One, you're holding a device upon a neck for a few minutes at a time. Another, a band around the arm. So I guess there's some preference there, and it's a shared decision with the patient.
That's exactly right. One talks about it with patients. How sensitive are they? Where is their pain? If they're having a lot of pain anteriorly, they may be good candidates for Cephally or head of term, or the device may bother them too much without cutaneous allodynia, and they won't be able to tolerate it. And then an arm device or a magnetic device might be much better for them. The arm device, the remote electrical neuromodulation device, is the most discreet. That one can be put under a sweater, under a shirt, turned on. Nobody knows it's on. It buzzes for 45 minutes and people would not know that it's on there. And in the preventive trial, that device worked in prevention in the second month of going 45 minutes every other day compared to sham. So it worked very rapidly in prevention as well as quite effectively in prevention for all the primary and secondary outcomes. So from a convenience and discretion standpoint, the remote electrical neuromodulation device is probably the least objectionable, and it has the advantage of being both acute and preventive. But the Cephally device, people can buy. And once they own it, then the only cost for using it is $25 for 3 electrodes, which have to be renewed about every 2 or 3 months. The cost of the Cephally device goes up and down. It's around $400 one time to own it. Monthly payments are available, while the remote electrical neuromodulation device is $49 for one device, and each device has enough juice in it to treat 18 times. So if somebody's using it every other day, that's certainly enough for a month. Plus, a patient can use it acutely on top of the 45 minutes every other day. And then the device cost, there are different deals with respect to how much the devices would cost, bundles of 3 and so on later. Those two are the most affordable at this point. The other ones have various limitations on price, which we can go over. The most important thing to know about the Cephally and the head of term devices are that they don't require a prescription. Patients can buy those without a prescription. All of the other ones require sending a prescription to the company, and the neurologist needs to get the address and the fax number or however they're going to send their prescription to the company to get those devices for patients.
So you spoke about high frequency migraine. What about chronic migraine?
Well, they all have either explicit approval for all of migraine, or their clearance is broad enough that it looks like it covers all of migraine. For example, the remote electrical neuromodulation device was explicitly cleared for both episodic and chronic migraine. the chronic migraine clearance for that device came after a case series for it. We don't have any randomized control trials, to my knowledge, that were explicitly for chronic migraine. For example, the regulatory trial on the single pulse transcranial magnetic stimulator involved people who had anywhere from 4 to 24 migraine days per month. So it included people with episodic and chronic. However, having said all of that, I use them all in episodic and chronic migraine. And in addition to the lack of side effects, in addition to the safety and tolerability, these devices can work when medications have failed. And Peter Goadsby, I always quote him on this. He says that you have a patient in front of you that's had 20 or 30 medications fail. That just means that the targets for those medicines were not appropriate for that particular patient's migraine. These devices modulate the brain, and they therefore modulate targets that we know about and targets that we don't know about. And there are a great number of patients for whom medicines fail and for whom non-invasive neuromodulation is effective. And they are at one end of the spectrum of appropriate patients. They're the ones who you've tried a million things and everything's failed, either due to lack of efficacy or adverse events. The other end are the people early on who don't want to take medicines for one reason or another. They may be tech savvy, they may like to embrace new technology, and they can use them primarily acutely or as an adjunct to an existing treatment plan. And there are those who are taking multiple medicines and having not perfect control, but have a high potential for drug-drug interactions. Again, you can add non-invasive neuromodulation and not have to worry about that. Finally, I can't resist mentioning one area that I always teach my fellows about, which is in a patient in whom adherence or therapy commitment is a problem. You're always a little nervous about sending them off with a prescription for a drug and not being sure whether they'll follow through or adhere properly. With the non-invasive neuromodulation devices, they have to have the skin in the game. They have to make the commitment, and you're shifting the locus of control to the patient. If they fill it, if they use it, if they come back, that's great. If they don't do that and they disappear, you haven't done any harm. Above all, do no harm. So we do use it in that area as well.
Great. So I think you hit most of the indications for prescribing these treatments. Let's talk a little bit about mechanisms of action, because it's really very interesting. And as you mentioned, there are targets that we think we know, targets that we don't know, but go for it.
I'll just give you my simplistic way of looking at these. I think that the way they work is they modulate the brain by peripheral access to central pathways. And one can actually adjust frequency and intensity and wavelength in some of these devices and get paradoxical effects. Over the years, we've learned what the appropriate frequency, pulse width, and so on these devices should be to achieve the goal. Let's start with the remote electrical neuromodulation device. That works by a very unique mechanism. It's a psychophysical reflex called conditioned pain modulation, which has been described, and in which pain in location A inhibits pain in location B. And we know this from psychophysical research in which the mechanical pressure pain threshold in the great toe is greater if a patient has the contralateral hand put into a bucket of ice water till it really hurts. And you can put a lot more pressure on the toe before it hurts. And what the REN device does is the patient adjusts it and buzzes the arm until it really hurts, and then moves it down below the pain threshold, but it's enough to activate nociceptive afferents. And so the nociceptive afferent input from the arm is terminating the migraine, which is in a different location, via a brainstem reflex. It's very clever. The front stimulators, cephaly and hedaterm, I mentioned, go in on supraorbital and supratrochlear trigeminal branches, and they do send signals down to the trigeminal cervical complex where they likely have inhibitory effects. There's also some cortical change that's been documented on functional imaging with long-term use of those devices. And remember that the combined occipital trigeminal neurostimulator also works in the front via those nerve branches. 3 devices then work over the forehead in that way. The non-invasive vagal nerve stimulator sends a signal in on the vagus and ascends through the thalamus and has inhibitory effects on thalamocortical pathways, and for the most part does not have efferent vagal impact on cardiac function and GI function. It's mostly ascending inhibitory and thalamocortical pathways that are affected by the NVNS. Now, interestingly, both the NVNS device, so the vagal nerve stimulator, and the single pulse transcranial magnetic stimulator, both interrupt cortical spreading depolarization. And so both of them can terminate aura, which is caused by cortical spreading depolarization. And the STMS device also inhibits thalamocortical pathways. It's interesting that these 2 devices that work by such different mechanisms, one going in on the vagus, one a magnetic pulse posteriorly, both inhibit thalamocortical pathways and cortical spreading depolarization. And finally, the combined occipital trigeminal neurostimulator sends inhibitory pathways through the greater occipital nerve into the trigeminal cervical complex, pretty similarly to what we do when we do greater occipital nerve blocks for migraine. Each of these then rides these peripheral access pathways to modulate central pain pathways.
Excellent. And you were indicating earlier about this Berlin Wall and the difference between acute indications, preventive indications, and the blurring. So when we think about mechanisms of action, what are these devices telling us about the migraine brain?
Well, it's not a single switch, is it? The study that I always show the residents and fellows was an N=1 study by Schulte and Arnamai that was published several years ago in Brain. And this was a patient who agreed to have functional imaging every morning at 10 a.m. for a month and not take migraine medicine during her 3 migraines across that month. And what was seen from a functional imaging standpoint was stereotypical changes in functional connectivity between hypothalamus, upper brainstem, and trigeminal cervical complex, in which there was a change in the relationship of those areas of the brain going into an attack and then a reset after the attack. Same for each of the attacks. It would seem to me that these devices can modulate slowly the relationships involved in that functional connectivity, as well as acutely terminate attacks via certain mechanisms. So we know that occipital nerve blocks can stop a migraine, so it makes sense that if you stimulate with an inhibitory stimulus along the greater occipital nerve, should be able to stop a migraine. We know that conditioned pain modulation involves termination of pain in a different area from where you're activating nociceptive afferents. We know that interrupting cortical spreading depolarization stops aura. So we can find our way to how these devices work both acutely and preventively. I don't think we have all the answers, but I think we're getting smarter about it as we go.
And so you spoke about the FDA clearance across the board for these devices and the confidence we can have in its safety. Let's talk a little bit about contraindications. I've read pacemakers being a contraindication. What other contraindications should we be aware of?
Well, for the non-invasive vagal nerve stimulator, the presence of vascular disease is a relative contraindication, and obviously indwelling devices for most of these non-invasive neuromodulation devices are generally, if not explicitly contraindicated in the prescribing information, one would hesitate to use them. Of course, it depends on what kind of implanted device one is talking about, but nonetheless, I tend to shy away from them. If they've had injury to the skull, where you're thinking about having the patient put a non-invasive neuromodulation device on, I would be hesitant about that. Having said all of that, it's very rare to have a patient where there are contraindications to all of them. And generally, there are not a lot of contraindications. I'd be a little hesitant in people with vascular disease. I would definitely be hesitant in people with cardiac arrhythmias. But I might be tempted to use, for example, cephaly or head of term or even the remote electrical neurostimulator in somebody with known vascular disease.
Great. So why don't we talk a little bit about the other indications? We spoke a bit about migraine, but let's talk about trigeminal autonomic cephalgias and any other indications that you're aware of.
It's a very quick discussion. Only one of these devices has FDA clearance for the trigeminal autonomic cephalalgias, and that is the non-invasive vagal nerve stimulator, the gamma-core device. And in fact, in the VA system, the gamma-core device becomes the first-line device for treating patients, for example, with cluster. The device is cleared for the acute treatment of episodic cluster headache attacks. And a patient would do 3 2-minute stimulations over the neck, wait 3 minutes and do 3 more 2-minute stimulations if needed, and can treat up to 4 attacks or 24 stimulations in a day. It doesn't seem to work for acute treatment of chronic cluster attacks, so be aware of that. It's also FDA cleared for the prevention of cluster headache, both episodic and chronic, but only as an adjunctive add-on. This was from a German study in which patients were on standard of care cluster prevention, and the NVNS device was added in one group and not added in the other group. And the number of attacks per week was considerably lower with the NVNS device, and the subcutaneous sumatriptan and oxygen use was also decreased. So the FDA cleared it as an add-on for both episodic and chronic cluster headache treatment. Very interestingly, the NVNS device was also cleared by the FDA for treatment of paroxysmal hemicrania and hemicrania continua. These are two trigeminal autonomic cephalalgias that are indomethacin responsive. In fact, response to indomethacin is part of the diagnostic criteria, but there are an awful lot of people that cannot take indomethacin, and 2 2-minute stimulations 3 times a day, either acutely or preventively for paroxysmal hemicrania or hemicrania continua, have been found to be effective in a few small case series that the FDA used to clear these devices. This NVNS device is the only therapy that is cleared by the FDA or approved by the FDA for the prevention of chronic cluster headache, and the only therapy that's cleared by the FDA for paroxysmal hemicrania and hemicrania continua. Indomethacin doesn't have an FDA approval. So this device can be very helpful in patients with trigeminal autonomic cephalalgias.
And we spoke a bit about chronic cluster headache. I think we should spend some time talking about sphenopalatine ganglion stimulator, not available, but promising, and also says something about the biology.
The sphenopalatine ganglion is the final common pathway for the efferents causing cluster headache. We know that cluster has a generator probably in the ipsilateral posterior hypothalamus. From there, neurons go to the superior salivatory nucleus, a parasympathetic seventh nerve nucleus, and then preganglionic parasympathetics go from the superior salivatory nucleus to the sphenopalatine ganglion, where they synapse. Postganglionic parasympathetics are the efferents that go out for most of the cluster headache symptoms, the lacrimation and the rhinorrhea and the diaphoresis. An implanted SPG or sphenopalatine ganglion stimulator was invented, and this device was screwed in above the teeth, could be put in with minimal conscious anesthesia, and it did not have any indwelling batteries or wires, and an external stimulator could be recharged and programmed like a paddle to turn the stimulator on, and it worked both acutely and preventively for both episodic and chronic cluster headache. It received CE approval in the EU and based on one randomized control trial. And there was a completed regulatory trial in the US. Peter Goadsby was the principal author on that. Again, it worked well. Again, it worked both acutely and preventively. But there was a problem with the toxicology work in the animal models. And even though it had CE mark in Europe, the company which developed it and which marketed it went bankrupt. And as a result, the intellectual property and the remaining devices were purchased by another company. And that company actually submitted and received from the FDA a breakthrough device designation several years ago. But so far, the device has not seen the light of day again. And it's really a shame because it was a very dramatically effective treatment for cluster. And one last point I can't resist making about this is if one set the frequency low in terms of the stimulation of this device, one could trigger a cluster attack in the patient. And if one set it at a high frequency, it essentially gave a block to the outflow from the SPG and it would terminate the cluster attack. So it was dramatic evidence that we understood the anatomy of cluster and could turn the volume up and volume down, turn on attacks and turn off attacks.
Excellent. Well, I hope we hear more about that.
Me too.
Let's talk about the future. What other devices should we be on the lookout for?
There are several devices that work on the trigeminal system or the vagal system, but enter through other peripheral branches, some of which are already approved in the EU. And these, for the most part, go in through branches around the ear and are posterior auricular. But there is one in the EU that actually works, I think, similarly to the remote electrical neuromodulation device, but goes in via the wrist. There's also a device that has already completed several randomized control trials, which pulses through the ear air pressure and appears to work both acutely and preventively by pulsing through the ear. There was a device that got FDA clearance that was a stimulator or a modulator of the vestibular system. And that device got full FDA clearance for treatment of migraine. And the company pivoted and decided to move into a different therapeutic area. But again, that might see the light of day. And I remain optimistic that there will be other non-invasive neuromodulation devices that will be appropriately tested over the next several years, and the companies will move fairly rapidly to get FDA clearance. It's a lot easier to get FDA clearance than approval for a drug. And that enables smaller companies who are nimble to develop new ideas in neuromodulation.
So it seems like there's been a lot of progress, but also the financial aspects that go into technology. And maybe we need to figure out some type of crowdfunding issue to kind of help push these companies forward.
Yeah, I want to tell you about something you may not be aware of, which adds to the misery of the access problem. We all know about the Centers for Medicare and Medicaid Services, CMS. In June of 2022, CMS essentially designated any external peripheral electrical nerve stimulation by definition a TENS device with a capped purchase price average of $428. The external trigeminal neurostimulator over the forehead for pediatric ADHD, CMS capped at $36 a month. And the CMS requires a certain duration of effect in terms of how long the device should last before they'll cover it. So with respect to the remote electrical neuromodulation device, They said that devices, in order for them to cover them, the device has to have a minimum lifetime requirement of 3 years. And therefore, the remote electrical neuromodulation device, which has enough juice to treat 18 times, did not meet the 3-year requirement, and they priced that as a zero reimbursement. So the problem that CMS put together is that if you go to the trouble of developing one of these devices, you really can't go down the CMS pathway to get reimbursement. Now, fortunately, the VA and the Department of Defense has been willing to cover these at appropriate cost for the company and minimal cost to the patient, if any. But it is a complicated problem for us to get access for our patients. I would say that the access is the biggest problem of all in the use of non-invasive neuromodulation for neurologists.
Absolutely. And I'm really glad that you touched upon that, because that's a real practical issue and certainly an advocacy issue.
The problem.
Yeah.
Because I think we have randomized control trials that show these devices work and work well. The FDA's looked at them and they're safe and tolerable with non-significant risk. They play a very important role for therapy of primary headache disorders, and nobody can afford the half of them.
Absolutely.
There are several devices that have clearance in either the EU or the UK. One is a kinetic oscillating device. One is a transcutaneous direct current stimulator. There is a combined front and back 2 units that's made by Cephaly that has CE mark. And actually, there's a device called the Mind, MYND device, that's got clearance in the UK that's similar to Cephaly and Hedaterm. Depends where you live, whether these devices are cleared by particular countries, whether there's reimbursement, whether they have CE mark. But unfortunately, when I talk to my European colleagues, for the most part, they have the same problem we have. Patients can't afford them for the most part. One thing we didn't talk about is which of these devices is cleared in pediatrics. And I'm happy to say that 3 of them are FDA cleared for both adolescents and adults. And those are the single pulse transcranial magnetic stimulator, the non-invasive vagal nerve stimulator, and the remote electrical neuromodulation device. And in adolescents, very often, and I don't need to tell my neurology colleagues this, the adolescents don't want to take drugs. And the parents themselves are often very amenable to having a kid put on one of these devices when they get a migraine and not have that child on a daily medicine or even using some of the available FDA-approved medicines such as triptans during their attacks. So I would encourage you to think about the use of these devices for adolescents, the STMS, the NVNS, and the remote electrical neuromodulation device, because, again, all 3 of them are FDA cleared for both acute and preventive treatment of migraine.
Well, I know this technology is wonderful for many of our patients. Access is an issue. But if we really talk to many of our patients, we know medication adherence is a problem. Lifestyle adherence is a problem. And so at least for the right patient, it's nice to have other options.
I really agree. And I must say that I've integrated these devices in my practice. And when I'm busy, I don't think a day goes by or every other day goes by where I'm not suggesting one of them to a patient.
Well, thank you so much for being on the podcast and sharing your knowledge.
Well, thank you. I want to leave my fellow neurologists with a lot of hope about these devices. If you can talk to patients about the cost, you'll find they're very helpful as adjunctive treatment in your migraine patients.
Well, thank you for being on the November Headache Series Neurology podcast. And to our listeners, thank you again for listening.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.